Hi everyone, so you probably just finished up your splenic pathology PowerPoint. So we are going to roll right into our lymphatic PowerPoint. Now we have the term immune system and we also have our lymphatic system, and you're probably thinking, well, what's the difference? What are the similarities between these two? The immune system is this overarching, they're technically two different systems, but the lymphatic system is part of the immune system. So the immune system is like this overarching system that we have in our body that just the main purpose is to defend our body from foreign things, right? Bacteria, virus, fungus, all of those things. And then our immune system is kind of broken up into these different kind of types of these fighters, I guess you could say, and our lymphatic system is one of those types. So we'll talk about some organs that encompass the immune system and the lymphatic system in a second, but on a very basic level, the immune system is a network of tissues and organs that work together in different ways to help keep us safe and healthy from those foreign invaders. So they are constantly trying to fight off those, toxins, viruses, bacteria, infections. They're serving multiple different functions and ways to protect us from those substances. So now our immune system organs, as we said, the immune system is this overarching protective barrier, and the lymphatic system is a slightly different system, but it's part of the immune system. So we have some particular organs that are responsible for serving in the immune system and the lymphatic system. So we have our thymus, which is technically part of our lymphatic system, and this is where our white blood cells go to mature. We also have our tonsils or our adenoids. These are going to be kind of strictly related to the immune system. They are responsible for filtering bacteria that enter our mouth and our nose. We also have our lymph nodes or our lymph vessels and lymphatic channels. Those, of course, are going to be part of our lymphatic system, and these are going to help us to distribute those white blood cells, and they filter our lymphatic fluid. Our spleen, again, as we know, a very large organ in the lymphatic system. This controls the amount of red blood cells and also produces white blood cells. So very kind of multi-purpose in terms of the spleen, right? The spleen has an effect on our hematologic health, right? Our blood health, but then it also is part of the lymphatic system, which is inherently part of the immune system. So our spleen, it's an important little organ over there. And then we have our bone marrow. This is also still part of our lymphatic system. This is responsible for producing a lot of things, our red blood cells, our platelets, and our white blood cells. So kind of similar to the spleen in the sense that it's playing and serving two different types of systems, right? The hematologic aspect of the blood with the red blood cells and the platelets, and then also the immune system and the lymphatic system with the production of those white blood cells. Our skin is technically an organ that's part of the immune system because it serves as a physical barrier to prevent these viruses, bacteria, fungus, so on and so forth, from entering into our body and harming us. And then also our mucous membranes. Our body produces these mucous membranes, and we inherently have these mucous membranes to filter out those bacteria and those viruses and those infections. So that's why our nose has mucous membranes, our throat has mucous membranes, even our bladder and our genital regions, they have mucous membranes to keep out everything that should not be entering. So we've already kind of talked about our spleen quite a bit. It's our largest lymphatic organ. It's controlling the amount of red blood cells and blood storage in the body, and it's also helping us to create white blood cells. White blood cells are also known as lymphocytes, so those are going to be kind of used interchangeably with each other. And these white blood cells or these lymphocytes, they are going to be the defenders against any germs or foreign microorganisms that come into the body. They are going to, that whole immune response is producing antibodies against these foreign invaders to prevent them from actually harming us. And then that way also in the future, our body remembers those antibodies and it says, okay, yeah, I came in contact with that type of bacteria. I'm not going to let it enter into the host anymore, right? So we have that natural line of defense because we've already had a previous exposure. So our spleen is going to be very important in our lymphatic health and then therefore our immune health as well. So the lymphatic system, again, we've kind of talked about this a little bit already, but the lymphatic system functions to collect and filter excess fluid, also known as lymph fluid, and we'll talk about that in a minute, and then return it back into the bloodstream. So that's kind of how we have this chain that keeps going. This is vital to our body's natural immune defense. Once that fluid is absorbed in the lymphatic ducts, it's going to be known as lymph fluid. So we kind of accumulate and we collect all of this excess fluid that occurs in the body, right? So that's where these microorganisms can be located and these invaders can kind of enter into the body. Once it is entering into the lymphatic system and it's entering into those lymphatic ducts, that's when the body is going to process that fluid, right? And it's going to filter it and make sure that it gets rid of anything that doesn't belong there. Then it's going to kind of change into lymph fluid. So a second ago, I kind of jumped too far ahead on that previous point. But once it is already in the lymphatic system, that excess fluid in the body has now been filtered into lymphatic fluid or lymph fluid. This is a system of ducts and lymph vessels that are connected through, and that is how the lymph fluid travels throughout that lymphatic system. The fluid is going to be absorbed and then also kind of exported through the venous system, and it's going to be filtered to lymph nodes along the way. So our lymphatic system, taking it a step further, it's composed of lymph nodes, lymph vessels, lymph ducts, and lymph fluid. Our spleen is a lymphatic organ, but when we're talking mainly about the pure filtration and transportation of lymph fluid, we need to have this particular chain of events, right? We need to have a lymph node, we need to have a lymph vessel, a duct, and we need to have actual lymph fluid. Okay, so these lymph vessels, right? This is how everything is going to move throughout the lymphatic system and ultimately the immune system. So the lymph vessels are thin-walled vessels that are going to transport that fluid to various parts of the body, also to different lymph nodes. The ducts are going to be blind-ended tubes that absorb the fluid within the body and then transport that fluid to the lymph vessels. So before the lymph fluid even gets to a lymph node or to that lymph vessel, it's coming through a duct. Okay, we have these vessels that bring that lymph fluid into the lymph node. And then we also have vessels that bring that fluid out of the lymph node back into the lymph vessels themselves. So we have afferent vessels that brings that lymph into the lymph node, bringing that fluid into the lymph node. And then we have efferent vessels, and that is bringing that lymph back out of the lymph node. Okay, so it's a very particular relationship, and we don't need to get too far into it. But just bear with me. The lymph vessels are then going to transport the lymph fluid proximally, and it's going to be filtered along the lymph nodes, to the lymph nodes along the way. So it's going to move up the body, okay? The lymph vessels have valves in them to keep that lymph fluid moving in one direction, heading towards that proximal region. So our chain of events here, these should be little arrows. We have lymph ducts that go to lymph vessels, which would be our afferent vessels, which go into our lymph node. And then the lymph exits our lymph node via lymph vessels again, but this is an efferent vessel. And then from there, they are drained into the venous system and they continue to travel on proximally in one direction. So here we have the breakdown of kind of what these vessels looks like, what they look like, and what the duct looks like. Again, you don't need to get too into detail about this, but just be aware that there are lymphatic ducts and there are lymphatic vessels. There are different types of lymphatic vessels, and you need to know which brings the fluid in a lymph node and which brings the fluid out of a lymph node, and how they travel interchangeably. Here we are showing our afferent vessels taking that lymph fluid into the lymph node, and then these are going to be our efferent vessels here, taking it out, moving along that chain. Next, we have our lymph fluid. So we've kind of talked about this. We said that this was excess fluid that's kind of just hanging out in the body. But once it enters into our lymphatic system, it then becomes lymph fluid. So it's clear and colorless fluid. It's unfiltered fluid that is containing proteins, materials, nutrients, damaged cells, cancerous cells, foreign body particles, right? So some of those microorganisms that the body is trying to destroy are going to be able to be found in that lymph fluid. So this is, you know, this fluid that has all of these different products in it. Some of the products are useful, right? Nutrients, minerals, proteins. Some of the products are not useful, right? Because it's trying to get rid of these things, right? So it's trying to bring that fluid into a lymph node to be filtered out. Damaged cells, cancerous cells, foreign particles, microorganisms. We don't want any of that stuff, right? So we need to get that fluid filtered, right? So unfiltered lymph fluid, meaning we haven't filtered it through a lymph node yet, but that is pretty much everything that we are going to be able to find in that early lymph fluid when it has just entered the lymphatic system. We're finding proteins, minerals, we're going to find potential white blood cells, red blood cells, nutrients, minerals, all that good stuff, but then we're also finding things that we don't want in the body and that we need to say to the lymph node, hey, get that stuff out of here. So lymph fluid is going to be produced when the fluid leaves the capillary beds in the tissue, right? So of that human tissue, we have this excess fluid, and then it enters into the lymphatic system and becomes lymph fluid. So about 10% of our blood volume will actually become lymph fluid because our body is going to say, hey, I kind of want some of this blood to be filtered through the lymphatic system as well, right? Our hematologic system and our immune system and our lymphatic system are pretty closely related, right? Our red blood cells can't function without white blood cells and vice versa, right? We can't keep a normal, healthy level of immunity if our hematologic health is poor and vice versa. So some of our actual blood fluid is going to become lymphatic fluid or lymph fluid because we need to filter that blood. We need to make sure that that blood is okay too and that we don't have any microorganisms hanging out in that bloodstream. And you can see on this diagram here too, not to really get too in depth, but you can see that that exchange happens with the blood in the capillary bed, right? So our arteries continue to get smaller and smaller and smaller and smaller as they reach different parts of the tissue, right? And ultimately they become a capillary bed where the arterioles are in direct communication with the venules, right? So we have a capillary bed, which is where the arterial blood supply meets with the tissue of an organ and then also drains into the venules to get that all to go back into the venous system now. So at that capillary bed, that's where we have a networking opportunity, right? That's where we can say that our lymphatic capillaries and our lymphatic channels are going to communicate because that's going to be the easiest place for them to pick up any type of excess fluid in the tissue or excess blood in the tissue or any blood that needs to be filtered through the lymphatic system. So next we have our lymph nodes. So these are small bean-shaped glands. These are located all throughout the body. We mainly see these in the axilla, our armpits, the groin, and our submandibular region, or also our neck. They contain white blood cells that are going to be obviously useful to help fight infections, especially while filtering that lymph fluid. So our lymph nodes are going to be responsible for processing and filtering that lymph fluid. The afferent vessels, as we said, is what is going to bring lymph into the node itself, and the efferent vessels are going to drain it out. And it's important to know that our lymph nodes have a very particular composition. This is how we can tell if a lymph node looks normal or abnormal on ultrasound. So they most importantly, you need to see a hilum. So very similar to the kidneys, our lymph nodes, you need to find a hilum. This is where those afferent vessels enter and our efferent vessels exit. We also need to make sure that we have a clear medullary cortical differentiation. So our medulla is our inner portion and our cortex is our outer portion. Our cortex should always be nice and thin and hypoechoic. Our medulla should always be hyperechoic. Okay, and then we can sometimes see the lymph nodes surrounded by a fibrous capsule. So if we're looking on ultrasound here, here is our hypoechoic cortex, nice and thin. Here is our hilum, and here is our medulla. All of this region internally. Okay, so that's exactly what we want to see for a nice, healthy lymph node. Now, continuing on with that appearance, so we usually see lymph nodes located in chain. And as we said, that's kind of how they travel, right? They travel upward. They move proximally to the next lymph node, right? To continue to be filtered through so we can keep that natural, healthy immunity. So we're very easily and often going to see lymph nodes sitting right next to each other. And we call that a lymphatic chain or a lymph node chain. The body contains about 600 total lymph nodes, so of course we're going to see a lot of them kind of clustered together. The largest ones that we are going to see are usually going to be in the submandibular region. Very common for young women to have reactive lymph nodes, which means they are working overtime in the submandibular region. And then we also tend to find large lymph nodes in the inguinal canal and the axilla as well. So if we look here, you may question, this is actually a picture of a cervical chain of lymph nodes, so located in the neck. You may look at this if there weren't arrows pointing to it and say that this is all just another muscle layer, right? But it's not. These are all lymph node, lymph node, lymph node, lymph node, lymph node, and lymph node, right? So it's a chain of at least 6 lymph nodes right there. So normal lymph nodes, as we said, it's really important that they follow that classic composition. So we want to see an echogenic fatty hilum. We also want to see an echogenic medullary region. We want to see a hypoechoic cortex, especially when we're comparing that to surrounding musculature. They're going to be bean-shaped or oval-shaped. They're usually going to be about 1 centimeter if they are not reactive, meaning that the patient is not fighting off an active illness. They are also the size isn't super reliable as well because there are a lot of cases where, like I said, young women have these naturally enlarged lymph nodes in the submandibular region for no underlying illness or for no underlying reason. So the size isn't completely worrisome if it's larger than 1 centimeter. And usually we are seeing larger than 1 centimeter lymph nodes in those prominent regions. So in the submandibular region, in the axilla, in the inguinal canal. Now, if we happen to see a lymph node located near the porta hepatis, right, or the parapancreatic region or the para-aortic region, right, near the pancreas or the aorta, we do not want to see a large lymph node in that area. We do not want to see a lymph node measuring greater than 1 centimeter. That is really going to indicate to us that something abnormal is happening. But if we happen to see it in those other 3 regions looking really large, even 3, 4, 5 centimeters, we're not worrying about it too much. Our margins, good Lord. Our margins, we want to see nice smooth borders. We don't want to see any points to that cortex. We also want to make sure that we are documenting central hilar vascularity. So when we're putting our color Doppler on, we want to see the vessels entering the hilum and exiting the hilum. We need to see that hilar flow. That's what proves that there is still a hilum for that lymph node. Echogenicity, we want to see homogeneous hypocortex with an echogenic hilum and medullary region. And our cortex, we want to see it pretty thin for the most part. We don't want to see it any thicker than 3 millimeters, okay? We also want to make sure that we are measuring the anterior portion of the cortex and not the posterior. So what do I mean by that? So here, our first picture on the left-hand side, they are measuring the anterior portion of the cortex. We don't want to measure that portion. Okay, we don't want to measure the bottom portion of the cortex. And if we are questioning why, if you look at the picture right next to it, well, it doesn't really have much cortex on the posterior portion, right? So you want to be measuring where you're seeing that nice clear-cut cortex, and that is usually going to be the anterior region. We're not measuring the posterior region of the cortex. So again, we see our nice hypoechoic cortex. We see our echogenic medullary region. This is still totally normal right here. Still completely normal. Same thing with right here. And then our picture on the bottom right-hand side, we are showing the vessels entering that lymph node and then also exiting as well. So normal, healthy lymph nodes on ultrasound. So if we're looking at lymph nodes on the neck, it's really important for us to be aware of our neck compartments. And I know Chelsea has mentioned this to some of you guys, if not all of you guys, during lab at some point, but this is the purpose of finding and mapping cervical lymph nodes, especially in patients who have a history of thyroid cancer, who have had their thyroid removed before. So we're identifying the exact location of cervical lymph nodes. This is really helpful for planning purposes for a radiologist. There are 7+ regions that we need to be aware of. So on the next slide, when you're studying, make sure you pop back to this picture. Just show you really briefly. We have section 1A and 1B right over here. Sections 2A, 2B here. Section 3 is by itself. 4 is by itself. 5A and B located to the side of 3 and 4. 6 anterior, and 7 all the way down here. So those are going to be the compartments and the regions where those lymph nodes can be positioned. And here is just a little bit further compartmental identification. So section 1A is when we are considering these submental nodes. So we're underneath that chin portion, very similar, closely related to our 1B section. That's our submandibular nodes. Section 2 is the upper internal jugular chain, again, either in front of or behind the chain. Section 3 at the region of the internal jugular, the mid portion, extending from our hyoid bone to our cricoid cartilage. Section 4 is the lower portion of that internal jugular chain. Section 5A and B, a little bit more closely related to that cricoid cartilage and that posterior side neck. And our section 6 is anterior compartment from the hyoid bone to the sternal notch, and section 7 is really just right at that clavicular region where the clavicles tend to join. Okay, so lymph node characteristics, again, just kind of reiterating the normal here. We have that oval shape, we have that thin cortical tissue. And then if we are looking at a lymph node and we're questioning that it doesn't really look oval and it doesn't really have a hilum and it doesn't have a thin cortex, well, we're falling into the abnormal category. So if we see a lymph node that is round, that is abnormal. If we see a lymph node that doesn't have a fatty hilum, that is abnormal. If we don't see hilar blood flow, that is abnormal. If we see that cortical thickness greater than 3 millimeters, again, abnormal. So what is that going to look like on ultrasound? So some further characteristics of some type of malignant or worrisome lymph node, they are large, right? They're really, really big. They are round in shape. They are uniformly hypoechoic, and we no longer have that hilar differentiation. They can look heterogeneous. The cortex is going to be thickened. We can see microcalcifications. We can even start to see normal healthy tissue death turning into cystic components, right? We don't want to see necrosis of a lymph node. Our margins are going to be ill-defined, and our vascularity is going to be abnormal. So we're not having that normal blood flow into and out of the hilum, but now we're seeing peripheral flow around the outside of that lymph node, or it's super hypervascular and it's just lighting up like a Christmas tree. Those are all things that we don't want to see. So this picture here is really showing us the loss of that hilar tissue. We also see some ill-defined margins, particularly up here in this anterior portion. And this whole thing is just uniformly hypoechoic. So that's going to indicate to us that there's something abnormal happening with this person's lymphatic system. So abnormal lymph nodes, again, all of these Actually, all of these except the bottom, except for picture C, these are all super round, right? And we don't have a cortex and we don't have a hilum. And you may even like look at this picture with the color on it on the side and say, okay, well, here's your hilum here. But we do not want to see all of that vasculature happening. We don't want to see that. So we just want to see flow entering and exiting the hilum. We don't want to see any of these other characteristics associated with it. Picture B on the top, again, super round, no cortical medullary differentiation, pretty enlarged as well. So again, we don't want to see lymph nodes looking like that. And then picture C. So to me, my interpretation of this picture is that this is the whole lymph node. So pretty irregular, ill-defined borders, and we have numerous calcifications. So we don't want to see calcifications in any lymph node. So biopsies, we are often doing FNAs or lymph node biopsies. FNA is a fine needle aspiration. So this is something that you're probably going to be seeing and doing out at clinical. Whenever we see a suspicious looking lymph node, we want to question it. We want to get a tissue sample. So a core biopsy versus an FNA is all going to depend on the situation. A core biopsy is giving us a lot more tissue to test, and it's a lot more reliable, but it's a lot more invasive for the patient, and you can have a lot of bleeding from it. Whereas in FNA, we're taking a very small, thin needle, and we're trying to shake the cells loose in the lymph node and scoop them up into the needle. So we're aspirating those cells that we are shaking loose. Now, there's more room for error with a fine needle aspiration because there's a possibility and the potential that we won't even suck up any cells. And maybe if we do suck up some cells, maybe we missed the area of malignant cells, right? So there's definitely more false negatives with an FNA than with a biopsy. So it's all going to be decided by the radiologist and the indications per patient. And you can see on this bottom picture here, our core biopsy is heading right into the center of that lymph node. You can also tell that this is a core biopsy because you can see the hollow tube, right on the inside. So if you look at that needle, you can see that black line in between those two hyperechoic lines. That's showing the hollow internal lumen of the needle that the strand of tissue is going to be sucked into when they take that sample. So a palpable lump, this is something that we very often are evaluating on ultrasound, and a lot of times it can be a lymph node. So there are really important questions that we need to be asking these patients when they come in for any type of palpable lump. Okay, so the questions that we need to be asking, of course, how long have you noticed it? Is it painful? Does it get bigger? Does it get smaller? Have you been ill recently? Any recent weight loss? Do you have a fever? Any recent dental work, right? Because sometimes when we have dental work done, that can aggravate the lymph nodes in our neck. The Novocaine, the lidocaine, that can aggravate those lymph nodes. And then, of course, if you're having like a cavity drilled or you're having a root canal, you are more prone to bacteria entering in through your mouth, right? So now, do we have an infection from dental work? Have you recently gotten a vaccine? So any type of flu shot, COVID vaccine, any type of MMR booster, which arm did you have it in? That can produce axillary lymph nodes. So now with the prevalence of the COVID vaccine, we actually have to ask patients that question prior to them getting a mammogram, because if they've had a vaccine recently, that enlarged lymph node in their axilla can show up on the mammogram, and then we question if that's something, is that a normal reactive process, or is this an abnormally enlarged lymph node? So it's really important to get an accurate patient history, because we don't want to make or assume a lymph node is abnormal when in fact, actually, yeah, they just had a really bad cold last week, or they just got a vaccine, or they just had dental work done 3 days ago. So we want to make sure that we're asking those appropriate questions. So what are we looking for? Of course, it's important for us to correctly document any abnormal lymph nodes, or really any normal looking lymph node as well. We need to make sure that we're documenting a patient's palpable lump, even if it is a normal lymph node. So even if a patient comes in and says, hey, I have a lump on my arm, you look at it, it's a normal lymph node. Of course, we're still going to take pictures and document that. We need to have a correlation for that patient's complaint. If the lymph node is located in the neck, we need to document the palpable lump and show a couple images of the cervical lymph node chain bilaterally. That's to prove that, hey, this patient, they have a bunch of cervical lymph nodes. It looks symmetric on both sides. If the lymph node is in the axilla, we need to again document that palpable lump, show potentially any other lymph nodes that are located in that region. And some radiologists want to know the number of lymph nodes in the axilla. So again, even if you are looking at one palpable lump in a patient's armpit and it's a lymph node, you need to kind of look around a little bit and say, okay, actually there's 2, 3, 4. Oh, wait, there's like 6 or 7 lymph nodes in this axilla. Even though the patient doesn't feel those, you still need to document that number. When we're taking images of a lymph node, we need to make sure that we are measuring in all, we're getting all 3 measurements in 2 planes. So that's a little typo there. We are getting a length and sag, right? We're elongating that lymph node to get a length measurement. We are getting a cross section of that lymph node in transverse to get a width and a height. We also need to make sure that we are measuring that anterior portion of the cortex. We're getting color in that hilar region. We're documenting any other lymph nodes. We are counting the number of lymph nodes we see. We're also aware of our protocols. So if we're working at a site or working with a radiologist that likes contralateral imaging for comparison, you need to know when and how to do that. And lastly, many of you have probably seen a paracentesis, or we've at least talked about a paracentesis before. And usually when patients come in for this, it's to just drain that excessive amount of ascites and peritoneal fluid that they have in their abdomen. So sometimes when a patient has a lymphatic problem, there's a problem with their lymph transportation or filtering of their lymph fluid. When we do a paracentesis, this is what lymph fluid is going to look like. It's going to kind of look like coffee milk. So it's pretty gross. Usually when a patient just has, not regular ascites, but they just have ascites, that fluid is kind of yellow. It's a little bit more clear, right? Sometimes it's like a dark orange. But if there's an accumulation of fluid in the abdomen and the lymphatic system isn't working properly, we know our lymphatic system is responsible for filtering fluid. If it can't filter that fluid, where else is it going to go, right? It's going to go in that peritoneal cavity. So it's going to be lymph fluid located in the abdomen, just kind of free floating, hanging out, because the body obviously can't process and filter the way that it should. So just something to keep in the back of your mind, that if you're ever doing a paracentesis and you're looking at the drain and you see something that's looking kind of murky and kind of brown, chances are it could be lymphatic fluid. So not a ton of really complicated information on this PowerPoint. You don't have to get too crazy in depth about the anatomy and physiology of the lymphatic system. Kind of everything we've just touched upon today is what is expected of you. So try to correlate this information back to that splenic pathology. And if you have any questions, please feel free to reach out.